Welcome back to Roadmap to Residency. In this video, we are tackling pediatric emergencies, which are some of the highest yield and most frightening question stems you will face. We are not going to reteach all of pediatrics today. Instead, we are going to train your eye to spot the crashing child in a vignette and to pick the one correct emergency action quickly. We will cover status asthmaticus, diabetic ketoacidosis in children, the difference between a febrile seizure and epilepsy, and anaphylaxis. For each one, we will read a realistic question, stem together, and walk through why every answer choice is right or wrong. If you find this helpful, please like and subscribe and stick around to the end for where to study and how to work with our expert tutors. Here is our game plan. First, we will learn to read a pediatric emergency stem the way a doctor at the bedside does, by recognizing the child who is decompensating and deciding what to do right now. Second, we will practice matching the specific clues in the stem to the single correct emergency action, because in these questions, doing the right thing first is everything. Third, we will walk through 4 classic vignettes together. Those are status asthmaticus, diabetic ketoacidosis in a child, febrile seizure versus epilepsy, and anaphylaxis. For every question, we will explain why the correct choice wins and why each distractor fails. This video sharpens your test taking. Pair it with your question bank and a trusted pediatrics review resource for the deep content. Strategy 1 is to read the vital signs and the last line first. In a long pediatric stem, it is easy to drown in the history, so train yourself to jump to the final sentence. In emergencies, it almost always asks for the next best step in management or the best initial treatment. Once you know what is being asked, go back and hunt for the clues that answer it. Then anchor hard on the vital signs and the work of breathing. The heart rate, the respiratory rate, the oxygen level, the blood pressure, and the mental status will tell you how sick this child really is. A child who is tiring, gone quiet, or barely moving air is unstable, and that single observation usually points you straight to the correct emergency action. Strategy 2 is to recognize the unstable child, because the whole question turns on it. The test writers love to hide danger signs in plain sight. A silent chest with almost no air movement, a child too sleepy to drink, weak pulses, cool mottled skin, or a dropping oxygen level all mean this child is decompensating. The moment you see those, the answer is immediate stabilization, not more observation, and not a slow outpatient plan. The second half of this strategy is to treat before you test. In a true emergency, the life-saving action comes before the confirmatory study. Give oxygen, give epinephrine, give fluids, or protect the airway first, and only then order the labs or imaging. Be very suspicious of any answer that delays treatment to wait for a result. Before we hit the questions, let us name the 3 distractor traps that show up again and again. The first is the confirm before treating trap. It dangles a test, like a blood gas or a chest film, in front of you when the child clearly needs treatment right now. In an emergency, treat first and let the test follow. The second is the wrong setting trap, which either sends an unstable child home or admits a perfectly stable one. Anchor on the vital signs and match the intensity of care to how sick the child actually is. The third is the adult reflex trap. Children are not small adults, so be wary of answers using an adult dose, an adult first-line drug, or an adult rule that does not fit a child. Keep these 3 in mind, and the wrong answers start to light up on their own. Let us work our first question. A 6-year-old boy with asthma comes to the emergency department with severe wheezing and trouble breathing for several hours. He is sitting forward, speaking only in single words, and using his neck muscles to breathe. His oxygen level is low, and his chest is tight with very little air movement. The question asks for the most appropriate next step in management. Look at the choices. Obtain a chest film before any treatment. Give oxygen with inhaled albuterol and ipratropium plus systemic steroids. Prescribe an oral antibiotic and send home. Or reassure the family and observe without treatment. Take a moment. Picture this child in front of you and decide which action you would take first. Then come with me to the walkthrough. Let us reason through it. Single-word speech, accessory muscle use, a low oxygen level, and a quiet chest with poor air movement are the hallmarks of a severe asthma flare that is not moving air. This child is unstable and tiring out, and the stem is begging for immediate treatment. So the correct answer is to give oxygen together with inhaled albuterol and ipratropium and systemic steroids. That is the first-line bundle for a severe flare, and it goes after the breathing problem right away. Now the wrong answers. Getting a chest film first is the confirm before treating trap, and it dangerously delays care. An oral antibiotic treats an infection this child does not have. Reassurance and observation simply ignore a child who is barely moving air. Each wrong choice waits or does nothing while the child decompensates. Treat the breathing first, every time. Question 2. A 10-year-old girl arrives with vomiting, deep, rapid breathing, and a fruity smell on her breath. For the past week, she has been very thirsty, urinating often, and losing weight. She is drowsy, with dry lips and sunken eyes. Her blood sugar is very high and her blood is acidic with ketones. The question asks for the most appropriate next step in management. The choices are: give a rapid, large bolus of fluids and then start high-dose insulin quickly. Start careful intravenous fluid replacement and then begin an insulin infusion. Give a dose of insulin under the skin and send her home. Or give oral fluids and recheck the blood sugar in the morning. Notice this is not asking you to make the diagnosis, it is asking about the safe order of treatment. Pick your answer and come with me. Let us break it down. Thirst, frequent urination, weight loss, deep, rapid breathing, a fruity breath, very high blood sugar, and acidic blood with ketones are the classic picture of diabetic ketoacidosis. This child is dehydrated and acidic. The correct answer is careful intravenous fluid replacement first, and then an insulin infusion. The fluids restore circulation before insulin drives sugar and potassium into the cells. Now the traps. Giving insulin under the skin and sending her home, or just giving oral fluids overnight, are dangerously inadequate for a child this sick. And the rapid, huge fluid bolus paired with very fast high-dose insulin is also wrong, because in children that aggressive approach raises the risk of dangerous brain swelling. The safe answer is careful fluids first, then a steady insulin infusion. Now let us separate the febrile seizure from true epilepsy, because the test loves to make you choose between reassurance and a full workup. The simple febrile seizure has a recognizable picture. It is a child between 6 months and 5 years of age, with a brief whole-body seizure lasting under 15 minutes, triggered by a fever, who returns to normal quickly and looks well afterward. When the STEM paints that picture with a reassuring examination, the answer is reassurance and treating the source of the fever, not a seizure workup. The STEM tips toward epilepsy or serious infection when it adds red flags. Watch for a seizure without any fever, a long seizure, focal one-sided shaking, a child who stays drowsy or abnormal afterward, neck stiffness, or a bulging soft spot. Those details push you toward imaging, a spinal tap, or further evaluation instead. Question 3. An 18-month-old boy has a brief whole-body shaking spell lasting under 2 minutes during a high fever from an ear infection. Within minutes, he is back to his normal, playful self, and his examination is completely normal. There is no neck stiffness and he is feeding well. His parents are understandably terrified. The question asks for the most appropriate next step in management. The choices are: order brain imaging and a spinal tap right away. Start a daily long-term anti-seizure medicine. Treat the fever, reassure the family, and treat the ear infection. Or get an electroencephalogram before discharge. Think about the picture we just described and decide whether this child needs a big workup or simple reassurance. Then join me for the answer. Here is the reasoning. A child between 6 months and 5 years, a brief whole-body seizure well under 15 minutes, a clear fever, a quick return to normal, and a reassuring examination together define a simple febrile seizure. This is benign, so the correct answer is to treat the fever, reassure the family, and treat the underlying ear infection. No seizure workup is needed. Now the distractors. Brain imaging and a spinal tap are the overkill trap when the child looks well and shows no signs of meningitis. Starting a daily long-term anti-seizure medicine is not done for a simple febrile seizure, and an electroencephalogram will not change anything here. Every wrong answer does too much to a well-appearing child. The answer is treat the fever and reassure the family. Our last topic is anaphylaxis, and this one is pure pattern recognition. Picture a 5-year-old who develops hives, lip swelling, wheezing, and vomiting within minutes of eating peanuts, and now the blood pressure is falling. The choices are intramuscular epinephrine into the thigh, an oral antihistamine alone, inhaled albuterol alone, or simply waiting to see if it resolves. The correct answer is intramuscular epinephrine into the thigh, given immediately. Here is the rule that makes these questions easy. Hives plus either breathing trouble or low blood pressure after an exposure is anaphylaxis, and epinephrine is always first. An antihistamine alone only touches the itch and never replaces epinephrine. Albuterol alone ignores the airway swelling and the blood pressure. And waiting throws away your one chance to stop a deadly reaction. Give epinephrine first, every single time. Let us bring it home. The way to master pediatric emergencies is to drill these stems in your question bank until recognizing the unstable child is automatic. For each topic we covered today, go deeper on the full clinical picture and the management steps in a trusted pediatrics review resource, and read every answer explanation, even for the questions you got right. That is how the correct first action becomes second nature on test day. If you want personalized help, visit roadmaptoresidency.com, where our expert tutors and residency advisors can build a study plan around you. If this video helped, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.